and welcome at the sixth edition of the international webinar series on gambling of the University of Gibraltar and Yale University, which webinars are organized in collaboration with the International Society on Addiction Medicine, the World Psychiatric Association, and the International Society on the Study of Behavioral Addictions. And today's topic is treatment for gambling disorder and other behavioral addictions. So I think we are looking forward a very exciting field of research. But before starting the presentations, first I would like to invite Professor Alex Baldacchino, President of the International Society of Addiction Medicine, to say a few welcoming words to us. Thank you, Alex.
Thank you very much, Zolt, and thank you for your organization and the organizing committee of these amazing webinars. And we are, on behalf of the International Society of Addiction Medicine and the World Psychiatric Association, we are very honored to be part of this process. I come from a landscape that once upon a time gambling disorders did not exist, or no one ever thought about the fact that behavior addiction has actually any scientific merit. But hey we have this wonderful researchers and wonderful collection of evidence that is going to make a difference to a lot of individuals who are experiencing these disorders. I'm taking this opportunity because in 2 weeks' time, the World Psychiatric Association is meeting in Vienna, and they're officially launching the revised, resuscitated addiction psychiatry section for the World Psychiatric Association. And for the audience here and beyond, for the ISSBA and others who are working hard in the field of behavioral addiction, behavioral addiction will be part and parcel of that section, together with pharmacologically based addiction. So that's excellent news, because in a way we can achieve better cross-fertilization and have a wider community within which people will be able to learn, but also to understand better this problem. So thank you very much, and I look forward to hearing John and David and Mark in the next 1.5 hours. Thank you.
Thank you very much, Alex. And I would also like to welcome all our 3 speakers, Professor John Grant and Professor David Hudgens and Professor Mark Potenza. And as I said, the focus will be the treatment of gambling disorder and other behavioral addictions. And the setup of the webinar is just our usual format. So as earlier, we'll have 3 talks, 15-20 minutes talks, and we would like to ask the audience to keep the questions until the end of the 3 talks. So unless you have a question which is really directly related to the talk, then it's possible to put 1 or 2 questions right after the talks, but rather we plan a general discussion after all the 3 talks were delivered. We have a webinar format of the Zoom. That means that the audience cannot directly ask, but we have the Q&A chat. So if you have any questions to the speakers, then please write down your question in the chat box, and then we will able to look at it, and the speakers will be able to answer. So that would be the best way to look at the questions. And okay, so then let's start today's webinar. And the first talk is from Professor John Grant, and I would say that it is almost not necessary to introduce John, as he is one of the most well-known and renowned researcher in the field of behavioral addictions and gambling. John is a professor of psychiatry and behavioral neuroscience, the University of Chicago, where he also directs a clinic and research lab on addictive, compulsive, and impulsive disorders. His research focuses on therapeutic interventions for impulsive and compulsive disorders, but also understanding neurocognitive correlates of these disorders. And John is author of over 400 peer-reviewed papers and scientific articles, 15 books, member of editorial board of many journals, and editor-in-chief of the Journal of Gambling Studies, just to mention few of the activities and achievements of his work. So John, thanks very much for accepting for invitation for today, and the floor is yours to talk about the pharmacological interventions related to gambling and other behavioral addictions. Thank you.
Thank you very much. It's a pleasure to be here. And so in the space of 15, 20 minutes, I'm going to first talk about what we know about pharmacological interventions, and that won't take a terrible amount of time because it's still fairly minimal in terms of data at this point. And then I'm going to talk about some of the complications when we think about doing pharmacological interventions and what often complicates that picture a bit. So let me see. I think I need to go to slideshow. Well, I'll just move from this screen. This is my disclosure information. You know, currently, even though we've been doing research on pharmacological interventions for almost 25 years now, there is nothing that is approved by any jurisdictional entity for the treatment of behavioral addictions. I'll be talking about some off-label options and then some research grants that I do have financial relationships with for research, but they're irrelevant to this talk. You know, so I'm going to be talking generally about gambling, and as many of you are well aware, this concept of behavioral addiction, I think, is still a work in progress, actually, which ones we include, which ones we don't. When it comes to the treatment intervention, really, other than gambling, most of the data is going to be case reports, case series, open label studies, occasionally a double-blind study, but the lion's share of it really still is with gambling. So I think one has to take that with a bit of a cautionary statement. Is gambling the same as all the others? And therefore, what we know about the pharmacological intervention of gambling will apply, should apply. We're not sure yet. I mean, if you think about, by analogy, what we know about double-blind studies, say for alcohol, don't always apply equally then to cocaine or opiates. I mean, that perhaps within this behavioral addiction, there will be enough difference between many of these behaviors, and even within the behaviors, that some of the treatment options that we talk about for gambling may be more specific to gambling and even to certain subgroups within gambling disorder. I'm just going to give an overview, looking at sort of classes, if you will, of medications, based sort of on a bird's eye view of mechanism of action. You know, so the one class are opiate antagonists. I present this slide, and the details of this slide are really less important than just thinking about the overall class, because it's been done in a few studies. We have a few studies now of naltrexone and nalmefene in certain jurisdictions for the treatment of gambling disorder. And these were, and this one goes back again almost 25 years now, and this is still probably the best data for pharmacological interventions, the use of opiate antagonists. The idea being that by decreasing at least the urges for gambling, that one can then modify their behavior more effectively. And this was again shown in nalmefene as well. it has been shown in kleptomania or compulsive stealing. There are case reports in compulsive sexual behavior. There are case reports in internet addiction. So it does seem to be, as many people have written in the literature, perhaps a pan-addiction drug of some sort. As many people will know, it's generally used for the treatment of alcohol use disorders or opiate use disorders. And so I think this is, again, it would be lovely to have more studies and larger samples, and we'll talk about the kind of the complications of why our database is small overall internationally. But at least the opiate antagonist area do seem to be at least an area of potential promise for getting more medication approaches for the world of behavioral addictions. Now, one could sort of say, well, if a behavioral addicted person doesn't have urges, does it work, right? I mean, and this is one of the questions: are these drug classes going to be effective enough for the disorder as a disorder, or are they really more specific for certain symptomatic subtypes within the disorder? These studies were done just with the disorder, generally enrolling people who had fairly strong urges. So it's consistent, but that would await, I think, larger studies where one could really parse subgroups by having enough people to really understand what would be the best approach. The one thing that we did find by looking at some predictor analysis is naltrexone tends to work better the stronger the urge, and for family histories of substance addiction. And so this may be two, at least, predictors, if you will, when you see patients who don't respond to it, whether they have those predictors or not. The other class of medications to just mention briefly are the antidepressants. And the antidepressants are obviously a wide class. Most of the early data was looking at SSRI antidepressants. There have been some with bupropion, both in internet addiction as well as in gambling. And what has largely sort of made these studies less beneficial or predictive of use for most people is that the data is very mixed because of this immensely high placebo response that was seen in these early studies. As I show here, this is just one of many studies. I could show a slide. This is one from a very old paroxetine study. And what was intriguing about this, as you see, is that the placebo response is quite high. And I think one of the complexities of this area is that this shows that the placebo response was still going up after 4 months of treatment with placebo. And I'll get to some of that in a second, but that means that a drug would have to be intensely, successful in order to overcome that very high placebo response. Now, is this just that these studies were done early on when people really weren't talking much about gambling, and this may have been the first time that many of these people even knew that an option existed, perhaps? This was an international study with a couple sites in the US and in Spain, so it's not specific to a region. But I think that to really understand this placebo response, and we see this across the behavioral addictions, I've often thought of it as a disclosure therapy response, that sometimes when people have these behaviors that are out of control, these naughty little secrets, let's say, that just telling somebody, even as part of a clinical trial, does a lot to relieve some of the burden that they're having. However, how long will that placebo response extend is really difficult for study design. Then we have some glutamate drugs, and acetylcysteine is not really technically a drug, if you will. Most jurisdictions, it's a vitamin or a nutraceutical. And this has been studied in substance addictions. It's been looked at in case series for sex addiction and in gambling as well, with some benefit looking at total behaviors of gambling as well as urges. The thought being that maybe it too is affecting some urges to engage in a behavior, although there may be some other data to suggest that when it was used with psychotherapy, that it cements cognitive behavior therapy more readily. So maybe it has some prefrontal glutamate effects. But this is often available in most places by over the counter without a prescription. And it just shows again that perhaps there are many ways of getting at this concept of urge. These have all been published so people can read the underlying papers if they're interested. I don't want to belabor it. Another approach through the glutamate mechanism prefrontally would be memantine, which, as many of you know, is a drug in most jurisdictions approved for the treatment of Alzheimer's. It's been shown to have some effects on impulsivity within the prefrontal cortex and cognitive approaches to things. Its data for alcohol has been mixed. It has some data, though, for gambling. And this was a study that we did, a 2-site study in the US that we did quite a while ago now. And this was actually targeting not only the disorder in an open label study, but really was looking at a task of cognitive flexibility, assuming that memantine would have some cognitive benefits for people potentially. And it did normalize cognitive flexibility in folks with gambling. So again, perhaps impulsivity, flexibility, these might be useful targets on a cognitive level for pharmacotherapy. And then finally, I'll just mention a slightly different take on it would be looking at prefrontal dopamine, and one can get at that through COMT inhibitors, which are often used for Parkinson's disease. And we performed a study looking at tolcapone, which is a COMT inhibitor in gambling disorder. It was open label, but again, it was also done in a way that we could see if we could have some predictors of who might respond. And this is an example that we could genotype the COMT genotype polymorphism to see if there was some relationship on a genotyping level. And I think all of this shows that we have multiple classes of medications, and we have some that may be more broadly useful, and then some that may be more specifically useful for differing subtypes within gambling. And one could argue then that these subtypes, if you can find, say, a certain genotype in gambling, if you can find it in some folks with sex addiction, some folks with internet addiction, et cetera, right? You see the thought process that then tolcapone could be across many of the behavioral addictions, even if it wasn't for each disorder writ large. So it might be a useful, again, should we look big or should we look small in terms of these individual characteristics? I think the just my final slide, and I just showing the complication, I think there are several things, and if you'll sort of I think that that have complicated our use of medication with behavioral addictions. One, we don't have a first-line approach to these behavioral addictions. Now, many people will say, oh, we should do some type of behavioral therapy. And yet, if you look at the evidence, there are no head-to-head studies really looking at behavioral therapy versus medication for the behavioral addictions. So we don't really know that behavioral therapy is going to be more beneficial than medication. One of the complicating factors, as I mentioned later, is behavioral therapies generally, particularly in the gambling world, have been compared to waitlist. Waitlist is not the same as a placebo. And clearly placebo has its own effects, its own biological effects in the brain. And so the fact that behavioral therapy often has stronger evidence, which it does not necessarily mean, depending on the study design, that pharmacotherapy may not be equally useful or even more effective for these behavioral addictions. But I think because we have some effective behavioral interventions, there's a lack of urgency often about doing research in this area and thinking about medication as adjunctive, or maybe only what one uses when all else fails. And I think that has sort of thwarted efforts of really putting a bigger focus on pharmacotherapy. I'm not so sure. I mean, one can debate that philosophically, politically, et cetera. But I think that that's probably added to the sort of lack of research around the world really doing this type of therapy intervention. Now, we do have, as I said, high placebo response. When we've looked at hundreds of gamblers to try to look at predictors, we do see a higher placebo response. They're very, sort of the effect sizes have been very minimal, but we do see a higher placebo response in depressed folks with gambling, and in milder gamblers, we see a higher placebo response. And as I said, sometimes the response can last up to 4 months. So we may have some very vague ways of trying to sort of minimize placebo response. But I would say the placebo response is there even in psychotherapy studies, arguably, right? When 60% of people respond to CBT, one questions how much of that is placebo versus the actual therapy itself. If people with behavioral addictions are given toward this higher, response due to a need for support, a need to just talk to people. Keep in mind natural recovery. We don't know about the other behavioral addictions, but in the gambling field, it's quite high, almost up to 40%. So when we do these studies, how many of these people would have gotten better? Just naturally, they were on this path and they were part of a study as well. So should we be doing something different in our designs? It's difficult to say. I think we do need some therapy versus medication as well. We need to mix it up a little bit and sort of, if we're going to start creating algorithms for treatment, not only do we need to know what may be effective in medication, but we need to know its relative effectiveness versus a lot of different psychotherapy interventions as well. So I think that the area is still ripe for a lot of research into these treatment interventions and the complications thereof. And my time is up. So thank you.
Thank you very much, John, for the exciting talk. And I don't see any questions in the Q&A box, which is okay. So as we said, we are looking for I see one from Pedro. What are your views on psychedelic assisted therapy to treat gambling disorder and other behavioral addiction? I think that's maybe we can keep these questions for the general discussions. I would suggest to do that because maybe other colleagues wants to contribute answering this question. So then I would suggest proceeding now. So thanks again, John. We saved this question for the general discussion, and I would like to invite you, David, to deliver your talk. And I'd like to also introduce you. So Professor David Hodgins is a professor in the program of clinical psychology in the Department of Psychology at the University of Calgary, Canada. And David is also coordinator with the Alberta Gaming Research Institute, and his research interest focuses on various aspects of addictive behaviors, including relapse and recovery from substance use and also gambling disorder. And he developed a brief treatment for gambling problems that uses motivation and enhancement model and research examining its efficacy. And many other exciting treatment-related and other research we know from the many papers published by David. So again, welcome very much here, and thank you for accepting our invitation, and the floor is yours. Thank you.
Thank you. Yeah, and thank you very much for the invitation. I'm very glad to be here. And I'm going to, first of all, my slides are showing properly. Are they? Yeah.
They look perfect, yes.
Yeah, thank you. Yeah, so I'm going to talk about sort of recovery change from a population perspective. And the reason for this is that we've said for years, well, many years ago we said only one in 10 people with gambling problems will seek treatment, and more recently that's been refined a little bit, and we can say that maybe 1 in 20 people seek treatment, or 1 in 5 people, I mean, depending on the particular studies. So I wanted to sort of learn more about these people who are changing and not seeking treatment, or not seeking treatment and not changing. And so this is a population perspective on some of those issues, and some of the issues that John raised about natural recovery and the different pathways people can take for recovery. And I'll just leave this, people can look more carefully, but this research is funded by the Alberta Gambling Research Institute. So yeah, so this is the problem I'm alluding to, that people with gambling problems, only 1 in 5 seek treatment. This is based on a fairly recent systematic review of the literature. The ranges are broad depending on the sample, but generally there's lots of people there who are not changing or are not seeking treatment and making change. And that's the focus of this, and trying to understand the public health implications of this pretty large group of people. So the study we did was a broader study where we recruited an online panel of people that was representative of the Canadian population. That was 10,000 people who gamble regularly. So it was enough people who were gambling regularly that lots of people were showing evidence of gambling problems. And one of the questions we asked those people was whether they had made a change in the last year, an attempt to change in their last year. And we had a nice size sample of 900 people who had evidence of a gambling problem, who said that they'd made an effort to change their gambling in the last year. And those are the folks I'm going to tell you about now. We were able to weight this to our national population sample, and you'll see that in a second. So these are the people that acknowledged or indicated that they tried to cut down or quit in the past year. And that represented about 60% of the people in the sample who had some evidence of gambling problems. So, that's our first kind of optimistic finding, is that a lot of people are making a change or trying to make a change in any particular year. We asked them whether they did this primarily on their own or whether they had the help of other people. And about 10% of people said that they had relied on the support from somebody else. It wasn't relying primarily on their own. And of those, then some of them said that they had engaged in some sort of formal or informal treatment with a professional or a self-help group, and we'll see that in a second. And then some of them said that, yeah, they got the help of others, but it was really very informal in the form of family and friends. But over here, you've got a large group of people who said that they were trying to cut back, but were saying that they weren't seeking treatment or getting kind of the help from others. So of course we can try to kind of get people to move into this other square and rely on the help of others. But the question is, what can we do for these people that aren't relying on other people but are making a changed attempt? So just in terms of Canadian statistics, we have 40 million people in Canada, and this is what I kind of show our health policy people, that we have in any particular year almost 100,000 people who are trying to do something about their gambling but aren't accessing our formal treatment. So it's a big group of people that we perhaps can be doing a better job of providing service to. So that's the basis of research that we've done over the last number of years, but also others are doing really around the world. And that's the notion of promoting self-recovery. How can you arm people in a way that they can actually be successful in these attempts to change? And so originally we had self-help workbooks, and now, of course, there are different online interventions. Some of them are completely self-directed. Some of them provide a little bit of guidance in the form of interaction with a counselor of some sort. But the notion is that we're really arming people to kind of do better at self-recovery. And I think the evidence is that these are helpful, but the challenge is that people don't necessarily engage well with them. So we still have lots to learn in terms of how to make these successful types of interventions. Some of them are available to the public, but given the amount of research that's been done, there's surprisingly little available to the public in terms of people having access to these self-recovery type interventions. But certainly the notion is that what we provide people on the web and the information when people reach out for information should be evidence-based and helpful. Okay, so back to these people who tried to change on their own. And I mentioned that some of them tried to change on their own, and some of them did something that would be categorized as treatment. And I'll talk about those treatments in a moment here. But we looked at their demographics, their gambling histories, their comorbidities, and so forth. And this is how they are distinguished, how you can distinguish these two groups. With large sample sizes like this, there's a lot of statistical significance. So we're really looking at effect sizes here, and medium and large effect sizes in particular. So you can see in terms of the demographics, gender did not differ. The people who indicated that they were trying to change on their own were slightly older. They were slightly less likely to be married. No differences in employment. As I mentioned, everybody had some general evidence of a gambling problem. But if we looked at gambling disorder in particular, certainly the people that sought treatment tended to have more severe problems. And this is a pretty consistent finding in the literature. And of course, related to that, higher problem gambling severity index scores. Looking at the number of types of gambling, and this is a large effect size where people who were trying to change on their own tended to gamble on fewer types, and really they were less likely to participate in every type of gambling except for lottery tickets. They were less likely to be online gamblers. They tended to be less vulnerable, less likely to have gambling-related fallacies, and less likely to have a gambling family history. People who sought treatment, were seeking treatment. These were all small effect sizes, but were all very consistent that they generally had more other mental health and addiction type problems. But again, small effect sizes, which surprised us a little bit. Sorry. And then finally, negative life events and childhood adversity. Again, people who were seeking treatment tended to have more negative life events and more likely to have childhood adversity, but again, small effect sizes for childhood adversity. So putting that together, who tries to change on their own? People with less severe gambling problems, less online gambling, less family history, less types of gambling, fewer types of gambling, and fewer negative life events, and they tended to be not married. We asked people of how successful were their attempts at change. Now, these were changes in the last year, so this wasn't a long-term success, but in the short term, And what we found was that whether people were doing it on their own or using some type of formal or informal treatment, that the perceived success was not different. And you can see that most people said it was somewhat successful. And then some people quite successful or very successful. And some people, of course, saying that it was not at all successful. But no difference between people who were seeking treatment and people who were doing it on their own. Now, remember, these were different people. We asked people why they didn't seek treatment. And this result is entirely consistent with other research done with more samples of convenience. Is the major reason people didn't seek treatment was that they didn't believe they needed help, or they felt too ashamed, kind of related to the stigma associated with it. And then, of course, some people were unaware of where to find help, and some people had negative ideas about the effectiveness of treatment as well. So a variety of reasons, but consistently, the top reason in this type of research is that people don't seek treatment, not because it's not available, but because they don't believe that they need it. So, yeah, who tries to change on their own and why? People with somewhat less severe problems, people who want to try on their own, either because they feel they don't need treatment or because they feel too ashamed to seek treatment. What were people choosing? So most people were choosing a couple of different options. And you can see that there's a variety, ranging from a few people who went to residential treatment. Most people were seeking some sort of support from a counselor or a family doctor or a professional. Self-exclusion was identified frequently. And of course, accessing self-help materials, so going to the web, doing searches, kind of getting information. So these efforts were usually in combination with something else. So a variety of different ways that people were seeking treatment. So how did people rate these in terms of their effectiveness? And you can see this is a scale from 0 to 3 in terms of helpfulness. Most of these options were rated kind of in the middle range. There was a little bit of differences ranging, at the top here, casino self-exclusion was rated as most effective. And I think it's good to be reminded that that's actually one of our most robust tools available to help individuals. At the bottom of the list was medication that was perceived as somewhat less helpful as well. We asked people how they became aware of treatment. Now, this is actually a smaller group of individuals that were in a follow-up study. So we didn't ask this of the entire sample. And I don't want you to pay attention to any of the specifics here. The takeaway message is that there were a wide variety of ways that people found out about treatment. And from talking to a family doctor, calling a helpline, media announcements, information at venues, family and friends found the information, doing a web search. So again, I think the take-home message here is that we need to make sure that the type of information available in all of these locations is sound and practical and helpful and directive, and kind of will move people in the right direction or support people's efforts in moving in the right direction. So the take-home message here is that there are a variety of pathways to recovery, and that people accessed a variety of types of support, and none were perceived as more helpful than any other. So all, in a sense, at that level could be supported. And self-recovery is a very popular route, but the routes to treatment also varied in terms of how people found out. Family and friends, clergy, health professionals, venue, webs all play an important role, and we need to keep that in mind. So the take-home messages to the public in terms of a public health approach is that I don't think we should be shy about promoting self-recovery. We do want to encourage people to access the supports that are available, but we should recognize that lots of people are uncomfortable with that, and we should promote the notion that, yeah, and you can actually make changes here and provide good, solid, practical behavioral advice on how to do that. We should promote an optimistic message about treatment, that it can be helpful and that it can work, and that can be promoted at the same time that you're promoting self-recovery, and also promoting the notion that treatment is available, and making it clear to individuals what the treatment options are, assuming that there are treatment options in those particular jurisdictions. And all of this would be consistent with what people in this sample seem to be telling us. So the next steps in the research we're doing is really to do a deeper dive. So, the advantage of this study is it was population-wide, and we were able to kind of get a sense of the actual incidence and prevalence of different aspects of people making changes. Now we're kind of trying to do a deeper dive by identifying people who are in treatment and really trying to get a much clearer understanding of their pathway of getting there. What were the various touch points and change points? How did that interact with recovery capital? And how does that differ in different jurisdictions? So stay tuned to that research maybe next year. So thank you. I'll stop there, Joe.
Thank you very much, David. Thank you for the great talk. And yeah, what I see here is that we are receiving a few questions, but not specific to the current talk. So let's keep us all to our original strategy to save these questions for the final discussion, and then we can now move further for the third talk, which will be about treating co-occurring disorders related to gambling disorder. And I will invite Professor Mark Potenza to deliver this talk. And Mark is a board certified psychiatrist with a specialized in addiction psychiatry, and he's a professor of psychiatry, child study and neuroscience at the Yale University School of Medicine, where he's also director of the Division on Addiction Research and Center of Excellence in Gambling Research, and Yale Research Program on Impulsivity and Impulse Control Disorder, just to mention a few of the leadership roles and responsibilities Mark is dealing with. And also Mark is on the editorial board of 15 journals, including being the editor-in-chief of the Current Addiction Reports, and also received many national, international awards for excellence in research and clinical care. I won't list all these, and also many of the papers and books of Mark, which are all very important contribution to the field. And now we are ready to listen to your presentation also. So thanks for being with us. Now on the other side of the webinar, I mean, everyone who visits our webinars, we know that usually we moderate these webinars together with Mark, but now he's also a speaker. So welcome. Yeah, thank you.
Thank you for having me, and delighted to be speaking. And I believe that what I'll be presenting today resonates with what our prior two presenters have already delivered. I'll be focusing on co-occurring disorders. I have a series of disclosures listed here with respect to gambling, gaming, legal, and pharmaceutical entities. And as we heard, the current status of treatments, while it's been developing for gambling disorder and other behavioral addictions, it still lags behind most psychiatric disorders. There are no medications with FDA indications for behavioral addictions or from other regulatory bodies. But as clinicians, we are in the position of trying to help people with these concerns with the information that we have. And perhaps since these disorders often co-occur with other psychiatric and medical and neurological conditions, that we should be taking these into account as we try to generate the most effective individualized care for people. So currently, while pharmacotherapies are being used, we also heard that behavioral therapies are widely employed, and there's support for multiple behavioral therapies. We also heard that there may be needs for active screening for gambling disorder as well as other behavioral addictions, because people may be unwilling or ambivalent about changing their behaviors. They may be experiencing shame, stigma, or guilt. And this article by Quigley describes some of the stigma-related considerations as related to gambling disorder. As such, screening might be particularly helpful, and this should occur, as we heard, perhaps in general populations, but particularly in other clinical settings. We also heard that most people, perhaps less than 10%, although as Professor Hodgins noted, the proportion or percentage may vary. Most people with gambling disorder do not seek treatment or an intervention, and as such, it often goes unrecognized and untreated. In multiple populations, work that was spearheaded by Professor Grant has shown that individuals within psychiatric settings, when they often do not have their impulse control disorders or behavioral addictions identified, this leads to poor treatment outcome. And thus, screening and identifying individuals may be important for multiple aspects, including with respect to the targeted psychiatric concerns that are being treated. So gambling disorder frequently co-occurs with other psychiatric disorders, with data from the National Comorbidity Survey Replication Study indicating that 96% of individuals with gambling disorder have one or more co-occurring psychiatric disorder, and 64% have three or more. And these co-occurring disorders might provide guidance for which treatments to use, particularly with pharmacotherapies, given no pharmacotherapies approved for gambling disorder. So what are the co-occurring disorders? These are data from the National Comorbidity Survey Replication, and substance use disorders are among the most common, but also mood and anxiety disorders as well as impulse control disorders frequently co-occur. The similarities between gambling and substance use disorders in multiple domains has led to the reclassification of gambling disorder together with substance use disorder in both the DSM and the ICD most recent additions or revisions. And these commonalities may be reflected in similar biologies and similar treatments. And as Professor Grant noted, we shouldn't carte blanche translate one treatment or one set of findings from one disorder to another without the empirical support. So while this provides a hypothesis for the testing of treatments, we do have to gather the data and determine the extent to which the similarities are borne out with respect to our anticipated or hypothesized findings or what we think might happen in a treatment setting. So going back now over 20 years, different neurotransmitter systems were proposed to play roles with respect to addictions or impulse control concerns. And we heard about the serotonin reuptake inhibitor paroxetine showing mixed effects, particularly in the setting of high placebo response rates. And in this small study that Professor Grant led, there was a concurrent decrease in problem gambling severity and anxiety in people with co-occurring gambling disorder and anxiety disorders. This in the open label phase, but there was also a double-blind discontinuation phase, which suggested that the medication continuation led to sustained improvement, whereas the randomization to placebo led to a worsening of symptoms in both domains. So if we think about the co-occurrence of gambling and substance use disorders, one widely proposed model for addictions is a dual process model related to how people process and are motivated by rewards in the setting of impaired impulse control. And if we think about the data that suggest that have investigated reward processing, individuals with alcohol use disorder now about 20 years ago were shown to have blunted striatal activations to monetary rewards. And since that time, it's been extended to tobacco use disorder, gambling disorder, binge eating disorder, and those at risk for addictions, those family history positive for alcohol use disorder, for example. And these findings have been linked to impulsivity, so less activation of the striatum correlating with more impulsivity in specific groups. And the data have been supported through meta-analyses where during the anticipation phase of monetary reward processing, individuals with substance use disorder or gambling disorder show blunted striatal activation, which appears similar to what's observed in other behavioral addictions like internet gaming disorder, although less data are available and the findings are perhaps less consistent across those studies. Now, if we think about pharmacological treatments of alcohol use disorder, there are FDA-approved drugs for alcohol use disorder, like disulfiram, naltrexone, and acamprosate. And we heard from Professor Grant that naltrexone has shown some positive outcomes in randomized clinical trials. There's a rationale for thinking that of these three drugs, naltrexone may be the one most worth pursuing with respect to its findings in alcohol use disorder with respect to reducing craving and thus diminishing engagement in addictive behaviors. And multiple clinical trials have found varying degrees of support for either naltrexone or nalmefene in the treatment of gambling disorder. So these are data from a study, a multi-center study that Professor Grant led. And one can see here that nalmefene at 25 milligrams per day, which is roughly equivalent to naltrexone at 50 milligrams per day, was associated with the most robust clinical improvement. It also had the most tolerability, and nalmefene in this study was superior to placebo. However, even at the most efficacious dose, there was a large proportion of individuals here, over 40%, who were not responders. So what were the factors that related to treatment outcome? In a subsequent study, again, led by Professor Grant, data were combined from two randomized clinical trials of naltrexone and nalmefene, and the most statistically robust finding associated with positive treatment outcome in the individuals receiving active drug was a family history of alcoholism, suggesting that there might be some biological features that cut across people with gambling disorder who may be at elevated risk for alcohol use disorder. Additionally, people who had strong gambling urges at treatment outcome also showed a better clinical response. And a different pattern was seen among people receiving placebo, where younger age was associated with better treatment outcome. So we also led, and this was led by Dr. Zmini Petrakis, where she integrated a assessment for gambling disorder in a randomized clinical trial of disulfiram and naltrexone for U.S. military veterans who had alcohol use disorder and another co-occurring non-gambling related disorder. And in that study, 6.3% of individuals met criteria for gambling disorder. This is considerably higher than in the general population. And over 1/4 had one or more criteria for gambling disorder. And in this study, disulfiram was associated with less alcohol abstinence in the group with gambling disorder criteria. So perhaps the naltrexone was helping both the gambling disorder and the alcohol use disorder, although follow-up assessments of gambling disorder were not obtained, only at baseline. Furthermore, the group with gambling disorder criteria showed less improvement in drinking days per week and in multiple psychiatric domains. Again, suggesting that the co-occurrence with gambling disorder is associated with a poorer treatment outcome, and by not identifying the gambling disorder, it may be leading to poorer outcomes here in the targeted domain of alcohol use disorder and perhaps other co-occurring domains. Now, another area where gambling disorder has shown biological similarities is with bipolar disorder, here with impaired control on Stroop tests linked to poorer, more reduced activation of the ventromedial prefrontal cortex. And in a study by Eric Hollander and colleagues, lithium was superior to placebo in both reducing problem gambling severity and mania rating scores for people with co-occurring gambling disorder and bipolar spectrum disorder. Now, a number of studies have compared drugs with one another, but in some of these studies where, for example, bupropion was found to be as efficacious as naltrexone, there were subsequent randomized clinical trials versus placebo, which were negative. So one should view these with caution. But based on the existing data, we have published a treatment algorithm, again, based on limited data, where we heard about N-acetylcysteine being a nutraceutical or over-the-counter dietary supplement that some people might be more willing to take than medications. But then based on co-occurring disorders, one can select a medication with the caveat that no medications are approved for the treatment of gambling disorder. Now, we also heard about behavioral therapies. Cognitive behavioral therapy arguably has the most support, and there are multiple forms, one by Nancy Petrie and one by Robert Ladouceur. There are other behavioral therapies like imaginal desensitization, which may decouple cues from behavioral responses, as well as 12-step interventions like Gamblers Anonymous. And in studies that have integrated behavioral and pharmacological therapies, most have not demonstrated added benefit of the pharmacotherapy. There are a few exceptions where N-acetylcysteine was superior to placebo with respect to more rapid diminishing of tobacco smoking dependence measures and longer-term follow-up, 3-month follow-up. Gambling disorder treatment outcome in individuals with gambling disorder and tobacco use disorder. Topiramate was superior to placebo in conjunction with psychotherapy. But again, most studies have not been replicated, and more work needs to be done in this domain. Now, another area which I think is a new and exciting area is digitally based delivery of care. So e-health or e-mental health may overcome geographic boundaries, limited appointment time, availability, or variability in terms of the delivery of therapies, particularly for approaches like cognitive, the CBT for CBT, which is computer-based treatment for cognitive behavioral therapy, which has been shown over the past 15 to 20 years to be an empirically validated treatment approach for people with substance use disorders. We're now applying a similar approach to develop an app to help people with gambling problems, and this app will deliver a cognitive behavioral therapy based on the work of doctors Nancy Petrie and Robert Ladouceur and others. So we recently reviewed the data for the existing gambling disorder apps using the mobile app rating scale, and found that there are certain features that link to better ratings, including aesthetics, the information, and these were with respect to the presence of cognitive behavioral therapy in the app and community engagement with the app. Now, another exciting area is with respect to neuromodulation, and there have been mixed findings to date of transcranial magnetic stimulation and direct current stimulation. These non-invasive forms of neuromodulation have the ability to alter brain activity within specific regions. To date, the dorsolateral prefrontal cortex have been targeted, where the behavioral effects on gambling behavior have been more limited. However, the data seem stronger with respect to decreasing craving. So I believe that more research is warranted in this area. The findings resonate with what's seen in internet gaming disorder, where Lulu Wu and colleagues have reported that direct current stimulation over the dorsolateral prefrontal cortex improves the ability to regulate emotions and regulate craving, consistent with a cortical control over subcortical brain processes with respect to regulating emotional and motivational states in addictive disorders. So based on the existing data, we've generated this complicated treatment algorithm, which considers both behavioral and pharmacological treatments. This is published in the Nature Reviews Disease Primer article that came out now 4 years ago. Now, another area that I think warrants consideration is with respect to transdiagnostic versus categorical definitions. So categorical being like those in DSM-5 or ICD-10 or 11, where there are diagnostic categories, and transdiagnostic features have been proposed to link more closely to biological factors and potentially be more amenable to interventions. So some of the transdiagnostic domains that might be relevant to gambling disorder are listed here with respect to reward and loss related behaviors, impulsivity and compulsivity, which we've heard a bit about, as well as cognitive functioning, which we've also heard about from Professor Grant. And so in one study where we directly compared and contrasted diagnostic group effects in individuals with cocaine use disorder, gambling disorder, and those without, and transdiagnostic correlates of impulsivity, we found two different biological results, where the group with cocaine use disorder showed relatively lower gray matter volume in medial prefrontal cortices that have been linked to craving and decision making, whereas impulsivity across the group was linked to smaller volumes within the insula, as well as subcortical brain regions like the amygdala and hippocampus. So it suggests that both approaches may warrant consideration. And with respect to impulsivity and compulsivity, the findings are mixed and may also relate to some of the ways in which impulsivity and compulsivity are assessed. So here in this negative randomized controlled trial of paroxetine that was mentioned by Professor Grant, it was found that at treatment onset, problem gambling severity related both to impulsivity and compulsivity, but changes in impulsivity related to changes in problem gambling severity, but changes in compulsivity did not. In the memantine trial that Dr. Grant mentioned, changes in compulsivity appeared to occur in the group with gambling disorder, whereas changes in impulsivity did not. So another area that Dr. Grant mentioned was with respect to genetic variance and treatment outcomes. And this, I think, is going to be important as we move towards more personalized medicine approaches. Some of the findings from alcohol use disorder have suggested that specific genetic factors may link to treatment response in a hypothesis-driven fashion. So, for example, allelic variants of the mu opioid receptor gene, OPRM, were linked to naltrexone treatment outcome with respect to a variant showing lower rates of relapse and longer time to return to heavy drinking. In a negative randomized clinical trial of as needed naltrexone for people with gambling disorder, this genotype did not show the hypothesized response with respect to gambling disorder improvement, and the opposite allelic variation pattern was related to improvement in emotional well-being. So again, the caveat that Professor Grant mentioned with respect to not immediately translating from one disorder to another is important. However, the study that he did show regarding tolcapone, which linked common functional allelic variants of the COMT gene to treatment outcome and hypothesized changes in brain function, seems very exciting. Although they are preliminary, they do support the hypothesis. So in conclusion, while we've made significant progress in terms of understanding the characteristics of individuals with gambling disorder and their treatment, there's much that we do not know. And we should, as clinicians, utilize the information that we have available to try to help people as best as we can. But additional research should address the existing gaps, including the barriers in people seeking treatment for gambling disorder that we've heard about from Professor Hodgins, and we should translate the information that we gain into better policy, prevention, and treatment efforts. So I'd like to thank a large number of individuals, and thank you all for your attention.
Thank you very much, Mark, and to all of you. And then now we can open the discussion. We have several questions. Maybe we should start with, we have a few on pharmacotherapeutical issues. Like one is there a role for lithium in managing gambling disorder? I don't know if John, Mark, or David, who wants to answer.
Well, I think Mark presented that slide, and it was used in a study with gambling and comorbid bipolar spectrum disorders. So I think it has a role. It might have even a larger role, right? I mean, lithium's been useful for impulsive individuals, depressed individuals. People used to think gambling was largely just sort of on the bipolar spectrum anyway, years ago. And so maybe if it's a piece of a wide range of impulsive behaviors, it could have a role. So I think lithium definitely needs to be studied further in gambling and across the behavioral addictions.
Thank you. anything to add? Or no, then maybe the other question is, thank you very much for the interesting webinar. I note from the first lecture that one of the studies presented on the naltrexone use in gambling indicated doses up to 250 milligram per day. Are these high doses advised in clinical practice?
Well, I would say advised, you balance that against the difficulty people have. In kleptomania, the mean dose was about 115 milligrams. In our first gambling study, the mean dose, effective dose, was 148 milligrams. Other studies suggested that perhaps the higher doses weren't beneficial overall. I think some people probably do need higher doses, and then clearly anybody using those would need to monitor the liver quite rigorously to make sure. Keep in mind, naltrexone was studied for obesity many years ago, 30 years ago or so, at doses of 300 plus, which is where the liver enzyme issues occurred. So I think that clinicians just need to balance, if they're getting improvement, what the level of severity of the gambling problem is, or the other behavioral addiction is to the person, and then make sure that any medication, regardless if you're going to use higher than recommended doses, is done with the patient's awareness of all the side effects and monitoring of those side effects.
And I would add that, so I agree with what Professor Grant is saying, and I would add that there is the black box warning regarding dose-dependent hepatotoxicity with naltrexone. In some of the studies, there were high rates of liver function test abnormalities. Some of this was reported to be linked to concurrent non-steroidal anti-inflammatory drug usage, which one should be mindful of with respect to providing patients with such information. And there are also some data, I believe, from one of the subsequent studies that Professor Grant published, that the lower doses of naltrexone appeared to be similarly efficacious as the higher doses in one of the randomized clinical trials. But again, I think the point that was made about individual responses and treating patients on an individual basis is important to take in mind. There was significant hope, at least for me, that nalmefene, given its lower potential for hepatotoxicity, would demonstrate efficacy in a more robust fashion. The clinical trials that were conducted suggested that the initial multi-center trial suggested a positive response. There was arguably a less robust response in the subsequent clinical trial, but among the individuals who received the active medication, if you looked at that subgroup, there seemed to be a positive response, with the caveat that there was still individual variability in terms of outcome, which I think, taking into account the naltrexone nalmefene study, looking at statistical predictors of response with the family history of alcoholism and the strong gambling urges at treatment onset, these are things to keep in mind from a clinical perspective.
Thank you. Thank you. And it was a little bit discussed, but there's also a question on antidepressants, if they could be, should be used. I don't know if you have anything to add on this.
I think they clearly the data is less robust for antidepressants than say, for example, the opiate antagonists. Having said that, I think some of those studies were done before we thought about strong predictors, subtyping, and the heterogeneity of gambling. And so I don't doubt some of the antidepressants have a home someplace in the behavioral addictions. The question will be for future research, I think, who will best respond, independent of those people with co-occurring depression or anxiety, but who will respond, directly, sort of the effects of an antidepressant. I think we'll await further sort of studies.
And I think this also raises a question about what people are defining as antidepressants. So, for example, ketamine is a medication that has a different mechanism of action than, say, serotonin reuptake inhibitors, and has been demonstrated to be helpful for people with depression. How it operates may be very different from serotonin reuptake inhibitors with respect to its not only its anesthetic effects, but what its proposed mechanism of action is with respect to synaptic plasticity, and how it may be integrated with psychotherapy is an ongoing area of study, and is one that holds potential for a number of psychiatric disorders, including gambling disorder and other behavioral addictions. Also with psychedelics. Similarly, it's an area of active interest for multiple psychiatric disorders, and the extent to which psilocybin or LSD or other psychedelic drugs may hold therapeutic potential, given what we're learning about not only the effects on the serotonin system, but also with respect to synaptic plasticity, is an area that we should understand better, particularly as there are more data from some of the disorders with which gambling disorder co-occurs frequently to date than we have data on gambling disorder or other behavioral addictions.
Yeah, that was one of the questions I was mentioned, but do any of you have further ideas or comments on psychedelic assisted therapy, if it should be used to treat gambling disorder? Don't know. John, any thoughts on this?
Well, I just think right now we have some evidence-based treatment interventions that should be used first. I think things hold the promise for things, but again, sometimes even something like psilocybin can be seen as a quick fix, and it can actually just further that sort of impulsivity aspect by feeding into people with behavioral addiction. So I think that first trying behavioral interventions and medications that have better evidence is probably sort of just more cautious, as sort of the future research is sort of being sort of accumulated on psilocybin and other psychedelics.
Okay, thank you. And any thoughts about interventions for drug-induced gambling disorder, like in the case of aripiprazole, or so drug-induced gambling?
It seems as if you stop the agent that's resulting in it, in general, you'll probably improve the gambling disorder. And then if you stop the agent, maybe it did or didn't actually induce it. And then again, you get back to treatments as usual, I think, would be the approach I think clinically most people would try. A replacement for whatever's, causing it, such as the aripiprazole or something.
Thank you. And then maybe moving towards the psychological related therapies and behavior, there's another question. If you were to recommend basic practical technical principles of how to create an online self-directed self-help interventions, what would that be? Your opinion, how different subtypes of gamblers in such an online treatment would require different approaches in some ways. Anyone wants to answer? David, maybe.
Sure. Yeah, I can tackle that one. I mean, I think there's one of our colleagues, Simone Rhoda in New Zealand, has done a series of reviews of different types of interventions and the different the content of those. And she did a big systematic review of psychological treatments for gambling and tried to identify all of the different components. And so that would be one source of what to look at. If you look at the different online interventions that are available, and Mark alluded to this as well, there's a lot of similarities among the different interventions, and generally they use a cognitive behavioral model. Some of them have been developed by trying to modify an existing treatment model or manual into an online intervention. Others have used more of a co-development type of approach with working with people who have been successful at recovering from gambling problems and looking at what principles seem to be important. Whether they've gone from that first direction or the second direction, the result actually looks pretty similar. So most of them, of course, contain some aspect of motivational interviewing, and then some sort of set of behavioral and cognitive type principles as well. The challenge has been, and we know that people use those strategies in recovery. So there have been a number of different ways that has been examined. The big challenge before us is really about engagement, and how do you get people to use these programs differently than they use the other apps on their phone, where they kind of will use them a couple of times and then they forget about them and move on and so forth. And so some of the ways that people are looking at getting people to use them consistently are through providing incentives. So combining a contingency management approach with an online intervention. And then, there's still debate about the value of providing counselor support to guide people along. For some people, that actually is a barrier and they are less likely to be involved. And for others, it's clearly a positive attribute. So there's a whole kind of array of different features. Some of them are, very clearly helpful, and some of them are more speculative at this point.
And if I could add briefly to that, I think the point that was made about most people who download the behavioral change apps don't use them is a very important one. Currently, I think Sally Gainsbury at the International Conference on Behavioral Addictions stated that the space of behavioral intervention apps is 90% of it is dominated by 2 apps, and of the apps, most people who download them use them at most once or twice and then discontinue use. So how to keep people engaged in sustaining behavioral change is really important, as is empirically validating the apps, since most of the apps have not been for gambling disorder have been empirically validated. So we don't know if they're working or not, but there are many that are based on empirically validated approaches like CBT. So while we're hopeful, we just don't have the data.
Thank you very much. And David, you mentioned Simone Roda. I wrote the name in the answer box also, if someone wants to look up the papers of her, and she was actually also a guest of us in a former edition of the webinar series. There are 2 more questions, more general ones on psychological interventions. Just if you have any further ideas on what the future directions could be, or just more generally, which are the most efficient or suggested approaches, or if you have any suggestion according to different gambler types. I don't know, any thoughts on these issues?
Yeah, I don't know more than what has already been said. I mean, I think, we do sometimes underestimate the ability of people we work with to know what they need. And I think, we need to, I think respect that client choice is very powerful and important. So, my general philosophy around self-directed treatments and digital treatments is that they need to be fairly straightforward and practical and applied, and sort of offered in kind of a cafeteria way that people can go to what they're most interested in using. Now, at the same time, all of the work that, the comorbidities, mental health comorbidities are so high that, we need to be, incorporating, attention to, issues of comorbidity. And I don't know that we've done that good a job of that within some of these online interventions and psychological interventions. So I think, there's some directions to go there, but I'm not sure that we're close to the solutions.
Thank you. So, well, we have 1 or 2 minutes left. So maybe I pick one more question, the link between adult ADHD and gambling disorder. So if you have any thoughts on this relationship or how to manage the treatment, or
it's been talked about for many years. I think Sheila Specker did one of the first studies looking at comorbidity rates being about 20% among people with gambling. We probably see similarly high rates across the behavioral addictions of ADHD. I think cautionary bit of advice is often people are probably misdiagnosed with ADHD when they don't have it, and many people are not diagnosed with ADHD when they had it. Attentional problems sometimes become the buzz phrase for people to say they have ADHD. And what we know is that attentional problems cut across psychiatric disorders in the big picture. Having said that, if somebody has the comorbidity, I think one has to sort of be cautious about certain medication approaches. Worsening ADHD with certain medications is always a possibility. Can you make people more impulsive with certain things? Can you make their gambling worse with stimulants? We don't really know the data. Clearly, in the addiction field, well-treated ADHD helps people with their substance problem often. But in gambling, it's a little less clear. Canadian studies showed that you can help the impulsivity of gambling by treating ADHD. It's a small study, but if you get the diagnosis of ADHD wrong and treat with a stimulant, you could worsen gambling. So I think it's definitely comorbidity that needs more detailed study. And I think the diagnosis of ADHD needs more caution than people simply being told they have ADHD because they have a problem with attention.
Thank you, John. Thank you, John. And thanks all of you for the excellent talks and the discussion. There were 2 general questions I wanted to answer. One, if someone could receive a certificate of attendance. And I also wrote in the Q&A that if someone needs that, then just write an email to our email address and we will send it. And there's also a question if the slides of the presentations are available on the website. And the answer is no, but we have recorded the whole webinar and that is available. So you can see it, and also you can advertise and inform your colleagues if they want to look at it, then that would be great. So thanks again for the talks. Thanks very much for everyone for being here with us today and being part of the discussion. And also, I would like to announce that the next volume of the webinar will be on Monday, 13th of November. That will be at 3 p.m. in Central European time, but we will obviously circulate the advertisement for the webinar with the topics and speakers and and we would welcome all of you. So thank you again for your attendance, and have a nice day further, or nice evening, and thank you very much. Bye.
You.
Thanks a lot. Bye, everybody.